All right. Good evening, everyone, and welcome to our second monthly online study club. I'm going to go ahead and introduce our speaker, Dr. Sameh El-Ebrashi. He obtained his Bachelor of Dental Science degree in 1993 from the University of Newcastle upon Tyne, and then completed his training in prosthodontics and earned a Master's of Science degree from the University of Michigan in 1998. He's a diplomat of the American Board of Prosthodontics, the American Board of Oral Implants, and a fellow of the American College of Prosthodontics. He's been in private practice limited to prosthodontics and implants in Portland, Oregon since 2006, and he's going to be speaking to us tonight on success versus failure with the all-on-4 technique. And he's since he's been in practice since 2002, he's done over 2012, he's done over 1,500 all-on-4 cases. So, Sam, welcome.
Thank you, Jay. Can you hear me okay?
I can hear you, and looks good. So, Sam, take it away.
Thank you, Jay. I appreciate the chance to speak for you. I've known Jay for probably 7 or 8 years. We both work with Dentsply, and I kind of got to know him at a couple of conferences, and I was always impressed with your CE and your study club and just sort of how involved you are with your GP. So I appreciate the chance.
Yeah, and Sam and I have the same birthday too, so although different.
Oh yeah, right.
I'm a few years old.
Disclosure. I'm not endorsing a particular technique. I don't think that one size fits all. All patients who you will see have signed consent forms with regarding photos and or stories. Beware a so-called expert. I will give you my definition of an expert a little bit later. Somebody standing or presenting, showing you the 3 best cases, you don't really learn very much from that. We all have complications. Some are patient-induced, some are lack of communication, some are just poor planning. Many times it's a combination of all the above. And I do try and use an evidence-based approach, or EBM, evidence-based medicine, whenever possible. So we're going to talk a little bit about demographics of the edentulous patient in the US. We think there's going to be up to about 245 million adults in the US this year. Baby boomers are age 55 to 74. That population may reach up to 73 million. And old patients, there's now a category of young, old, old, and old, old. And old is 84 and above. Old is that middle cohort, 75 to 84. And then there's another group from 65 to 74. And then typically in my private practice, or where I'm working now, is I'm dealing with patients with a lot of chronic diseases, high morbidities or comorbidities. Those patients have a decayed, missing and filled scores that are high. This is a patient that was referred from OHSU, the local university, and she complained. She said, my lower teeth really don't function very well. I said, well, what were you expecting? She said, well, I knew her lower denture was poor, but I figured with 2 implants, and you can see it's not connected to the implants at this point. She really expected it to function more like a fixed prosthesis. So patient, I guess PA or Q or consent is very important. And let's talk a little bit about patients according to age and gender and race. Total percentage of patients age 65 and above in the US about 8 years ago was about 18.6%. But when you go from the cohort 74 and above, it changes pretty significantly. 75 and above, it more or less doubles. No difference in edentulism rates, male to female. That's surprising to me. My experience has been it's higher in the men than it is with the women. And we know there are demographic and ethnic and socioeconomic differences, typically according to education. So I always used to kind of tell my students that if you have somebody with a Harvard MBA, they're not going to be asking you for a lower denture. So it really comes down to access to care and financial means. And again, non-Hispanic white, 17%, non-Hispanic black is almost 30%. And that is related to socioeconomic opportunities, not ethnicity per se. What is the leading cause of edentulism? Perio. This is a patient that was referred from Bend, Oregon, about 150 miles away. and she goes to see her general dentist, and all he can offer her is an upper denture and a lower denture. And so that transition to go from being dentate but with a failing dentition to full edentulism is pretty profound. Many of these patients have been isolated and sort of put away, that they don't really wander too far outside the house. Many of them have sort of struggled until they can no longer function. And there's some kind of triggering event. It may be divorce, it may be a child going to college, it may be a child graduating, it may be some kind of emotional reason to not to convince them, but to push them over that tipping point. And so we tend to use something called a biopsychosocial treatment model, where you think of the whole patient. What are her needs biologically, psychologically, what is she suffering from, and socially, how's it impacting her? And when we look at this paper by Felton that came out from 2016, that talked about complete edentulism and comorbid diseases, we know there's a significant correlation between periodontal disease and atherogenesis or atherosclerosis. And this is a patient, he's a musician actually, and he started braces years ago and never finished. You can see all the calculus here. And his kid was finishing college. He said, I'm embarrassed to show up for my son's graduation. And here is his upper and lower provisional prostheses. Sleep apnea for me is a sleeping giant. I have lots and lots of patients with undiagnosed sleep apnea, and I talk to them. I said, have you ever thought about a sleep study? And they say, oh, no, I don't snore. And then I'll ask their significant other, and they will typically say, I don't even sleep in the same room as him. And that the rate of obstructive sleep apnea varies. Male to female is roughly 2 to 1. It is correlated to body weight for sure, or body mass index. And there is a correlation in the genders. Male is higher than female, but we found in females post-menopause, they have a higher correlation. So we don't know if there's a hormonal impact, but there is definitely a relationship between a neck circumference of more than 17.5 inches and having sleep apnea. Diabetes is correlated to periodontal disease. As you can see here, it's going to be the 7th leading cause of death by the year 2030. Patients with less than 19 teeth have difficulty eating, and they're at greater risk for cardiovascular disease. Male patients with non-insulin dependent diabetes, they've got a 30% increased risk of perio. They're 22% more likely to be partially edentulous than non-diabetic patients. And partially edentulous patients with RPDs. This is a patient who presented with a lower partial. We know that diabetes mellitus increases with age. Tooth loss percentage increases with uncontrolled diabetes. And when you look here, 62% of diabetic patients use partials versus non-diabetic patients. And of course, there are many factors that are negative about being edentulous. So the prevalence of edentulism, 28% in the diabetic population versus 14%. And the patients who never remove their teeth and their rates of aspiration pneumonia. 10% of death from pneumonia in a patient in a nursing home could have been prevented by the patient removing their dentures. This is a patient who did not remove her prosthesis for 22 years.
Oh.
That's calculus, as you can see.
Yeah, I've seen those before.
Very fearful patient, Jay, as you can imagine.
Yeah.
And there's a correlation between edentulism and neuropathology. There was a study from Milwaukee where they had basically a dentist taking care of Catholic nuns. And he'd been their dentist for about 40 years, and he was following up with them. And they consented to post-mortem exam, and they found there was a correlation between dementia and rates of edentulism or partial edentulism. So there is a cognitive impact, and I don't know if that's nutrition and the ability to masticate and chew things that are high in vitamin B and natural fruits and vegetables versus a predominantly high-carb diet.
Yeah, probably also has related to ability for hygiene too, I would guess.
What do you mean by that, Jay?
I mean, if patients who have dementia are less likely to have good oral hygiene than those who are fully lucid.
Yeah, agreed. And this is how we used to do things. We used to have a whiteboard that we used to write everything on before we did a surgery. Now we don't do that. Now we have a piece of paper that we print up, we put up patient by patient, because We're worried about any kind of contamination or any surface that potentially could have any sort of contamination. This is sadly a fairly typical patient that we see. She's 77. She's here for an upper prosthesis, single implant. She has all the following: dry mouth, hypothyroid, hyperparathyroid, high cholesterol, hypertensive, stage 3 kidney disease, gouty arthropathy, arthritis, tinnitus, constipation, back neck pain, headaches, lymphadenopathy, anxiety, depression, insomnia, reflux, GERD, hyperlipidemia, osteoporosis, IBS, and she takes a lot of medication. If you look really interesting here, reminders for the day of surgery: no gun, hat, or bob tie. Pretty interesting gal. So what is polypharmacy? I'm sure you've seen those.
Oh, yeah.
Polypharmacy is when a patient is taking multiple medications and maybe over-the-counter medications. And the problems we've run into are the folks who are taking the ginsengs, the ginkgos, the garlics, because you get in there and you take out the teeth and you've got significant bleeding. So over-the-counter meds and herbal remedies and dietary supplements can definitely affect bleeding times. I don't know if you want to chime in on that, Jay. What's your experience been?
Most definitely. Almost every there's a list of medications that affect bleeding and clotting ability is huge, and especially with the herbal and holistic type remedies, I'd say at least half of them cause prolonged bleeding. Same thing with some of the dietary supplements. So especially down in Southern California, and probably up in Oregon too, you have patients taking a lot of these herbal remedies for their maladies, and may or may not report that to you on their medical history.
Correct. And so, considering that we live in a kind of a holistic part of the country, just like you folks do, we've run into this. We had one patient who was an older guy, Paul. He was in his 80s. We were taking out a few lower teeth, and he just took out the teeth. He didn't do any bone reduction, any implant placement. I said, "What's going on?" He said, "I can't stop the bleeding." And we asked him afterwards. I said, "Well, what's happening?" He said, "Oh, my wife makes excellent meatballs, and she puts a bunch of garlic in every night. I have 4 or 5 of them." So we asked them specifically.
Yeah, that's another culprit.
We found out the hard way. Yeah. Multimorbidity, more than 2 chronic health conditions, and it's associated with polypharmacy and adverse drug events. Definitely something that is common in Western medicine. They have less physiological and mental reserve capacity to deal with additional stressors, whether they are physical or psychological. Poor patient quality of life. These patients may have psychological issues and a higher rate of mortality, and definitely fragmented medical advice. That's a tough one to deal with. When we're doing our surgeries, we are sending a letter to all their providers, and it has to be signed off by everybody before we do surgery. And they get frustrated. The patients get frustrated, and some of the physicians will get frustrated. But it's very important because, go ahead, Jay.
That a lot of times, if patients go in a number of specialists, they don't really communicate with each other, and a lot of times the internist, who's kind of the captain of the medical ship, doesn't put it all together and doesn't give the patient all that information. And so, the patient may not know all the conditions they have and all the medications they're on.
And then when you're sedating a patient, somebody who has COPD, poor capacity to respond, and so on. So very important, especially when you're a stranger to the patient like we are, because we don't know these patients very well, but they have providers that have been dealing with them for 10 years. You rely on that person's judgment, his or her judgment, to help guide you and understand whether these patients are good candidates. And we probably have a dozen patients, Jay, that we were waiting for medical clearance on, or they were denied medical clearance. We did not do surgery. Within 6 months, those patients passed away.
That's
so you're dealing,
smart move on your part. A lot of times, I said, if the patient's seeing multiple doctors, even if they have their full medication list, these different specialists don't always look to see what interactions there are between all the medications. And definitely, the more medications, the more medical risks the patient has, medical conditions, the greater their risk for surgery is. So you got to really careful.
And when I first joined when I first joined the network, Jay, I was surprised that all the surgeons, or most of the surgeons that ClearChoice employed, were MDs. I remember thinking to myself, why the heck do we need an MD? A periodontist can do this. It's not that difficult. Then I saw the comorbidities and the polypharmacy and how we were dealing with a very sick group of patients that was significantly more challenging than my patients that are in private practice that have a little bit of borderline hypertension and type 2 diabetes with an A1C of 7.1.
Yeah, it's a very unique patient population. I think that goes to Clear Choice. Yeah.
Yep, absolutely. I agree with you. And so this is typically what happens. You have these conditions. You have a medication list. You get this complex polypharmacy and or adverse drug events. You start to have some decline. You get further chronic conditions. Your doctor throws more pills at you, and the cycle begins. And it's hard to get off that merry-go-round when you're taking this many medications, because medical health or medical care in this country is not necessarily geared towards prevention. It tends to be geared towards dealing with the status quo. So here is a patient who is a retired nurse. She was treated by the fellow that I bought my practice from. He did all this crown and bridge. She then went and ended up seeing a Kaiser provider where they really don't want to do crowns. So she's got probably 6 or 8 composites on each tooth. She has Sjögren's syndrome. She takes multiple medications. And she's trying to convince me to take out all these teeth. I said to her, I said, her name is Charlie. I said, Charlie, it's a pretty aggressive move. And she said to me, she said, I've basically raised the white flag. She said, I probably spent $20,000 trying to save the teeth. And as dry as my mouth is, and as deep as the decay is underneath the gum line, how much more time do you think you can get me? So it's a difficult conversation to have. And I used to be very resistant with these patients. But if every single restoration, she has sleep apnea as well, by the way. So if every single restoration has recurrent caries, and they're done reasonably well within the last year or two, what is the outlook for these? And how do you deal with a patient who's got chronic xerostomia or dry mouth? It's a pretty challenging situation.
Tough. Yeah, definitely.
And then what are the emotional effects of tooth loss? This is Helen. Helen came from Idaho. She had an iliac crest graft in the maxilla that failed. She had 5 implants in the mandible that were straight up and down. And I saw her parking her car, and I made presumptions that were totally off base. I thought, here I go again, another young person who has abused drugs and so on. And she came in, and she probably weighed less than 100 pounds. She said, I don't leave the house. I'm barely eating. I feel much older than my age, and I can't wear my dentures because I'm on chronic pain medication. What can you do for me? I said, well, until you quit smoking, I don't think it's a good idea to do implants in the maxilla. How about I make you a good upper denture, and we restore the implants in the mandible? And here she is about a year and a half later. She came back and she said, I'm doing great.
Yeah, totally
I
different
had a
person.
baby. She said, I had a baby, I put weight on, and it was all because of the teeth. And I sort of laughed with her, and I said, you didn't have a baby because of the teeth. She said, but the teeth allowed me to actually leave the house, get a job. So understand that you're doing something profound for patients.
Yeah, it's life-changing for patients like this.
Absolutely. And then being fully edentulous, according to the WHO, meets the criteria for physical impairment, disability, and being handicapped. And this is a patient that I treated in OHSU when I was working up there. She came to see me. She's got high acid intake. She grows her own vegetables and she pickles everything. And you can see the amount of erosion in the tissue. Yeah. Lots of acid. Yeah. And so how do you restore this case doing traditional crown and bridge? You're probably going to need to do endo on 6 to 8 teeth and cast post and cores potentially, and crown and bridge. And then what's the prognosis for those? Here she is in the mandible. So, you could have taken out 18, 31, 30, single implant in a bone graft in 19, single implant in 30, crown and bridge, and so on and so forth. Teeth are sensitive. This has got endo. That has endo. Prognosis is poor. So it's a different philosophy. And the interesting thing about this case, we actually did it as an upper all on 5. This implant had very poor torque. So Jeff Burstein, who's my partner, he placed another implant distal to it, and I think this thing, there's an indirect sinus lift, or it's very close to the sinus. And this implant had very poor torque. Jay, on the day of conversion, I came to tighten it and everything turned. But it did, the abutment still seemed to line up, so we just didn't use that implant while the provisional prosthesis was in situ, waited, and then came back and attached. But if you have low poor primary stability, you are going to have a struggle to load and convert without complication.
Yeah, I mean, we always, if we get low insertion torque or a spinner, we always bury the implant. But of course, that's if you're doing all on four, that's not an option for you.
Well, it is. I mean, if you place 4 maxillary implants and they're all at 5 to 10 newtons, you're not going to load them.
Okay.
And so the hard part becomes being able to predict that ahead of time and looking at the bone quality on your CT scan. But I think, and you know more about this than I do, that can be deceptive purely based on the CT scan.
Yeah. So Sam,
so
when you have low insertion torque and you're not able to load the prosthesis, how often is that, and how do the patients respond? Because I guess not working at Clear Choice, I always had thought that they always do immediate loading of everything.
Well,
that's their goal.
Think about it. Yeah. So in the mandible, most of the time you can load. I mean, I can count on one hand the number of implants that we didn't load in the mandible. And if a patient has a significant PA lesion ahead of time, you're actually going to go ahead and take that out and let things heal, especially if it's emerging where this is. So the mandible doesn't seem to be too much concern because it's typically type 1, type 2 bone, especially if the patient is dentate. The maxilla can be challenging, especially if you have a hollow maxilla or osteopenia or a sort of fatty cancellous bone where you can't get a lot of stability. And if that's the case, when my partner meets with them prior to surgery, we are talking to them. So if we have a patient who is missing 2, 3, 4, 5, 12, 13, 14, 15, and it looks like the bone quality is very poor posteriorly, we will place 2 tilted implants first. If we can have primary stability, we'll continue and edentulate the remaining teeth. If the torque on those 2 is poor, we just bury them, let them heal. Don't take out the remaining teeth. Wait till those 2 integrate, then come back, check them, make sure they've healed, and then you can extract the remaining teeth. So it's not a one-size-fits-all, Jay.
Okay. Good to hear.
Most patients hate to go from being dentate to edentulous in one full swoop. So we do whatever we can to avoid that.
Got it.
There is definitely a profile or an impact. An oral health impact profile allows us as dentists to quantify patient-based measures. This guy wants to eat a steak. She wants good-looking teeth. And typically this has to do with some negative dimensions. And it's a 3-dimensional way of measuring patient discomfort, dysfunction, and disability. So patients fill out this form prior to treatment, and then they fill it out after treatment, and we're able to get an objective comparison of their experience versus our preconceived notions. Mm-hmm. Because you may have a patient with a maxillary complete denture who has good speech, used to having a palate, and then you go ahead and you convert that patient into a fixed hybrid, and they complain about their speech. Or
that's interesting.
You may have a patient. I mean, it depends also on the relationship. Is it a class 2?
Yeah.
So phonetics can always be challenging.
Yeah.
This is a study from Australia where they had a look at physical pain and psychological discomfort and functional limitations. You can see that the P value is significantly different. So functional limitations when you dentate are different when you're being edentulous. The standard deviation is big. So this is 8.6 plus 9.33. We know that edentulous patients suffer more than dentate patients. And this is a typical patient. This fellow used to sing in Portland Airport for about 20 years. He's a Frank Sinatra impersonator. He has Parkinson's. He has dyskinesia. He has dry mouth. He has significant medical problems. And eventually his teeth were extracted. And he's been coming to see me for 5 years, Jay, asking for a pro bono case.
Yeah.
Every year for 5 years. And this time he came and he was shaking more visibly than normal. And I said, sure, we'll do it. So this is him. He can no longer sing because he can't tolerate his dentures. He has ample bone. He has well-fabricated dentures, good extensions, good stability, but simply very little salivary flow and dyskinesia that makes his head sort of bob up and down.
Yeah.
So how's that patient going to tolerate a removable prosthesis?
Not very well.
Here is the planning that we do. There are the ridges. You can see excellent ridge form. Obviously a little bit atrophic here. Here are some amalgam tattoos. And here is his medical stuff. Jay, can you explain to me what AV, atrioventricular block, is? Because I don't know.
So, yeah, that's basically the electrical impulse normally goes from the AV node to the SA node, the SA node, sinoatrial node, and the impulse is carried to the articuloventricular node, and then the current is basically, or the impulse is conducted through the fibers in the ventricles. So with an AV block,
Purkinje fibers, right?
I'm sorry.
Yeah, Purkinje fibers.
Yes.
Called, right?
Yeah.
See, I remember something.
So an AV block is when the impulse on occasion, and there's different types of AV blocks. There's type 1, type 2, type 3, that the impulse from the SA node doesn't get to the AV node on a regular basis. So it's a dysrhythmia. So they may miss heartbeats. They may have miss heartbeats. Sometimes it's just one, but if it's longer, like a third-degree block, the ventricles basically take up their own rhythm. So the AV node then acts by itself as a pacemaker. So you have the atrial rate, and you have the ventricular rate, which is one that's important. They're separate and not coordinated.
So
that's really debilitating. Yeah. And those are patients that are going to need a pacemaker so that they can have coordinated heart contraction.
And how does something like using too much epi affect a patient like that?
It would.
Or sedation.
It would increase the SA node firing. I don't think it affects the AV node as much, so it may increase the heart rate somewhat. And as long as it's like a type 1 block or a type 2 block, it may not be all that significant. I don't know the exact answer to that, but I believe it affects the SA node.
Right. Anyway, here is his medical history, and you can see so that his diabetes is controlled. Parkinson's, he's got a neurostimulator. He's got stage 3 kidney disease, polyneuropathy, hypertension, and we know this guy's a poor candidate for removable prosthesis. So I go through all the steps. I'm doing a diagnostic wax-up. I'm making sure my teeth are where they should be. I'm duplicating the prostheses in clear acrylic. Here are the windows we use, Jay, during surgery, so that Jeff, as he's flapping the case and reducing the bone, I can come and check the reduction. And then there's a trough on the lingual to allow me to check where they are, and those are his provisionals. I think that's a month later. Those are his PAs. Little bit of inflammation. So interestingly, with this patient, I wanted to check his manual dexterity to make sure that his dyskinesia wasn't going to be so profound that he wasn't going to be able to clean. I said to him, John, I said, if we're doing 40 or 50,000 bucks worth of work for you for nothing, you've got to be able to maintain it. So here's his provisional prosthesis. You can see the arch form is not ideal. Tissues are settling down. Here's the zirconia prosthesis, monolithic zirconia. In the mandible, AP spread's okay. It's not great. Those are straight abutments. These are 30 degrees. Lots of keratinized mucosa. A little bit of a longer cantilever on the left than the right. And the tissues a few months later, and there's his prosthesis. Sometimes if this cantilever is long, Jay, I'm going to do 3 premolars. But typically your cantilever is 1.5x your AP spread.
Okay.
So I think we're within that pretty significantly here.
Yeah.
There's his radiograph. MI. Here he is. He's now singing, got married, and he's changed his medication, and now his tremors aren't quite as much. And I asked him, I said, what's going on with your eye? He said he thinks that's related to his medication. I don't know. But he's doing well.
Good.
And I was able to get him a grant from the Academy of Osseointegration, so that helped defer some of our costs.
Oh,
And
excellent.
Straumann were kind enough to donate the zirconia prosthesis. So we use Straumann as our principal vendor for the monolithic zirconia.
Mhm.
And they're using something called Zircomzone or Pretau, which really is sort of the gold standard when it comes to zirconia prosthesis. As Brannemark quoted, the edentulous patient is an amputee to whom we should pay total respect and rehabilitation ambitions. Most of the time we're dealing with elderly patients, and it's a kind of a mixed bag of folks. They vary physiologically, psychosocially, and in the number and severity of diseases they suffer from. Challenges of dealing with these patients, medications, diseases, their mobility, what are their limitations socioeconomically? This is the most important one as far as I'm concerned. What are their physical and mental reserves, and do they understand what's going to happen, and who's there to take care of them should there be a problem?
Yeah,
The oldest
critically
all-on-4
important for all
patient.
surgeries. Yeah.
Yep. This is the oldest patient I ever treated, Jay. He was 94. We just did his treatment under local.
Yeah.
Yeah, he lives at the coast by himself, and we placed 4 implants in the mandible. I figured an upper denture would work well. His bite force was so strong, he consistently kept on breaking the lower, not the upper,
Really?
which tells you that his muscle tone and his masseter strength is still high. So even though he's 94, physiologically he may be 81.
Yep. Yeah, I
So
agree.
you don't look at the age per se. And then these are the types of things that we consider with medical clearance. How are they? What are they like from a psychological standpoint? This is the House classification. Are they philosophical? Are they exacting? Are they hysterical or indifferent? How much bone do they have? Is it any good? And what type of dentition, what stage are they at? This is Mary. Mary drinks quite a bit. She came in before COVID and she said, I want to get my teeth fixed so I can go to my grandbaby's graduation in Atlanta in May. Of course, there was no graduation.
Yeah.
When you look at the occlusal relationship, she's a challenging patient. And this is her on the left with her mom when she's a young woman. She said, I want to go back and look like that. I said, we all want to go back 20 years. It's not going to happen. So when you have this type of occlusal relationship, we did not do an upper and lower all-on-4. It was an upper prosthesis. I opened up the vertical dimension of occlusion, and I was able to adjust a couple of these teeth. Here's number 21. You can see it's tall right there.
Mm-hmm.
But I just plastied that. So just a maxillary all-on-4 and a lower flipper. This is our medical clearance, one of many. Before proceeding with the proposed oral surgery procedure, we'd like to ensure that the patient is able to be treated safely. What's the patient's cardiac risk? Does this patient have a history of heart attack or stroke? Can we use local epi with that much epi every 30 minutes? What's the other pertinent medical history? Are there any medical conditions we need to be aware of? Is the patient medically stable? The patient is scheduled to be monitored, blah, 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 using the following. Mm-hmm. We may be using Versed, fentanyl, propofol, ketamine, decadron, toradol, acetaminophen, and Zofran. Mm. And so we want to make sure that we can get clearance that is pretty comprehensive.
Yeah. Yeah, you don't want to take any chances.
Right, especially when you have patients that are medically compromised.
For sure.
This patient had many medical problems. Any comment on that sort of generic form, Jay? We have one for radiation, for bisphosphonate, we have one for pulmonary function.
I mean, it basically asks all the questions that you want to know, what you need to know to be able to determine if this is a patient who can tolerate the procedure.
Right.
Yeah, and recovery.
And then we will specifically go look at their medication. So let's imagine it's a patient who's got a history of stroke, and they're on Plavix or Coumadin. We're going to do an INR and so on. So we're really very, very careful about that. I always tell my patients the medical management is non-negotiable. Teeth are teeth. I can remake your teeth if you don't like them.
Yeah.
But I can't bring you back if you're gone.
Yep.
So we have patients say, well, I'm not going to get that medical clearance. I say, great. Here's your money back. Goodbye. It's a non-negotiable for us.
Yeah. Makes sense. Yeah, especially, I mean, you're doing major procedures, so definitely the right thing to do.
Yeah. Here is a patient. This is his optimized BP, according to his physician. 150 over 100, diabetes over 8, sleep apnea, smoking, and bruxism. And even though he's a big guy, Jay, we could get zero primary torque in his maxillary implants. Zero.
Really?
I
I would
submerged
think
them
he'd
all.
have really dense bone.
He didn't.
Hmm.
He didn't. It was all fatty bone marrow.
Wow. Were you able to determine that on the CT ahead of time, or it just wasn't
Nope.
diagnostic for that?
Found out the hard way, Jay. I presume because he was a big guy, but he'd been a 30, 40-year smoker.
Yeah.
And there is definitely a relationship. Go ahead.
Yeah. Yeah, definitely related to osteoporosis and the number one cause of implant failure.
Yep. And 4 years later, he came back, and I noticed he was wearing a red sock and a black and a green sock or something different. He said, my upper implants hurt. And I looked in his mouth, and he had tons of plaque. And I said to him, when was the last time you brushed your teeth or cleaned your teeth? He said, well, I water pick once a month. And I said, what's the point? Why bother?
Yeah.
3 out of 4 of the implants in the maxilla failed. They had significant infections.
Yeah.
And I said, we're not going to do it again. You're going to be wearing a denture until you can demonstrate that you're going to take care of yourself. So I look at non-medical, non-dental stuff. Is this patient taking care of himself? Do they have a significant? Yeah, very important.
Yeah, because we're treating people, not just teeth.
Correct. So let's talk about the ostectomy and the bone reduction that a lot of people have issue with. When you take out a maxillary central, that's probably 10 millimeters from the incisor edge of the CEJ. Once you've removed the root, how much socket is there left, and where does the head of your implant need to be, and how much planning are you doing to allow adequate space? And the adequate space is a minimum of 15 millimeters from the incisor edge to the head of the implant if you're using acrylic titanium. This is the planning I do, Jay, before cases. Jeff is doing his own planning, and he's referring to his CT scan during surgery. So he's planning, he'll go ahead, take out teeth, he'll go ahead and drill an osteotomy. Sometimes we'll take a pilot drill, place it in there, or a guide pin, and take a PA. What we're looking for is sound bony walls to prevent anything going up into the nasal cavity and or the sinus. There should be a positive stop.
Yeah. Sam, have you guys looked into, or are you using guided navigation, like the
real-time navigation?
Real-time navigation to get the implants exactly where you plan them to be.
No, we haven't, Jay. I think there's potential there. Bear in mind that Jeff has done about 2,500 of these cases.
Yeah.
So we will use a stereolithographic stent for complex cases to start the osteotomies and the pilot drills. But if your stent is off at all, you're in deep trouble.
Yeah.
So we're flapping cases. We're not doing these cases flapless, Jay.
Yeah. No. Yeah. Something like this you can't.
Right. Well, you can try,
especially if you do bone reduction.
Yeah. I mean, so I've seen cases online that some of the folks from Dentsply showed. Said, here is the case with the teeth. Here is the bone reduction guide. Here is the implant guide. Well, how accurate are those things going to be? And are you really reducing the bone exactly down to the level it should be according to their planning? I don't think so.
Yeah. It's tricky.
And this case was done by Ole Jensen. I know you know who he is.
Yeah. Oh, yeah.
And so this is the typical amount of reduction that you need from one arch to the other. You need a minimum of about 34 millimeters from here to here. Why is that? You need 15 per prosthesis, and you need about 4 millimeters for freeway space. So you got to have space for your framework, space for the plastic, space for the abutments, and very importantly, space for your hygiene. I call it the 4-5-6 rule. If you do not have enough space,
for sure.
Absolutely. If you don't have enough space, the patient and the prosthodontist or the restorative dentist keep paying the price over and over. Because the implants are successful, but there's inadequate room. And when I look at the cases that I did in 2006 from my private practice, I was like, oh man, there's not enough space. What about high smile patients? We could have a whole program on high smile and what causes it. Is it vertical maxillary excess? Is it a short lip? Is it super eruption? Is it a combination of all of the above? And so this is a list that I kind of came up with of what I look for. How much bone is available? How much bone can be removed? What are the implant dimensions after we remove the bone? What's the patient's transition line look like? If that's her smile line, you got all sorts of options. You could do orthodontic intrusion. If it was excessive, maybe you could do a Le4 and an impaction. There's many, many different ways of doing it. What's the height of the smile line? What is her lip length and how do you measure that? What's her lip support anteriorly and then in profile? What is your new proposed incisal edge position of 8-9 relative to the wet-dry border of the lower lip and speech? What's her video and vertical dimension of rest? Is she a class 1, 2, or 3, skeletal or dental? What's her closest speaking space? What do I mean by that? If you say to a patient, say 66, Jay, say 66.
66.
Your teeth didn't really touch when you said it, did you?
No, I don't think they did.
Now put your teeth together and say 66.
66.
So when somebody's VDO or their freeway space has been encroached upon, the teeth are too tall, meaning that when they're trying to pronounce certain things like Mississippi or 66, there's no room.
Yeah.
So we've got to use speech as a way of determining tooth position. Here is her planning. She's a postal worker. How much bone reduction am I going to do? How much of the implant is going to be a native bone to allow us to gain primary stability? And there's her provisional. She didn't like it.
Well, looks great.
Skewed.
Yeah.
She said it's skewed. It leans one way. I said, you don't hold your head straight. Well, that's how I hold my head. She didn't like how gummy she was. So I was able to move the teeth more apically because we did adequate bone reduction.
So you redid the prosthesis?
Yeah, but Jay, I do two prostheses, right? I do a provisional and a final.
And the final. Got it.
And now what I'm doing is, I also do a wax trying. So now what I'm doing is zirconia prosthesis. I do a provisional on the day of surgery, wait 4 months for healing, wax try and make a second provisional, correcting all the things they didn't like about that first one, make sure we get the all clear, we send that off to be copy milled. So we do 3 prostheses per arch. Finding that way that the rate of remakes has gone down. What happens when you don't do ostectomy? This is the case from Las Vegas. Look at that. Not a lot of room for your prostheses or your titanium.
No, not at all.
Now look at the cameo surface.
It looks like they weren't able to maintain it very well.
I mean, Jay, they can't maintain it because of the contour. Because there wasn't adequate bone reduction. You're fighting for restorative space. It's a ridge lap. How are they going to clean that? There's no chance of flossing it. You got all those convexities, and the food and the tobacco and whatever he has in there is just building up.
Yeah. Stays there forever.
Not a happy camper. Yep. My only solution for him was to open the video, make him a new prosthesis, what we call a Montreal bridge, with a titanium finish line on the undersurface because space is so limited. Can't really go back and contour the tissues at this point. Well, you can. Patients don't like that. Can't really reduce the bone. So, as JFK said, success has many fathers, but defeat is an orphan. We are all keen to show our good cases. Very few of us want to show our failure because typically you tend to blame somebody else for your failure.
Yeah.
There's a joke in my clinic. When it goes wrong, I blame the surgeon. And when I can't blame the surgeon, I blame the technician. And when I can't blame the technician, I blame the patient. Last of all, I might take responsibility myself.
Yeah.
But in reality, the buck stops with me because I'm planning the case from the beginning to the end.
Yeah. Although, we learned in medical school, you learn more from your failures than from your successes.
Yeah, absolutely. I agree with you. Let's look at this patient, very anxious patient. I'm not going to go through the list again because it's a similar list. Now look at his smile line. So Jay, tell me what you're thinking when you look at a patient like this. Is this vertical maxillary excess, or you can't determine that without a CT?
I mean, his upper lip is a little short, but he's smiling. So I would say it's more vertical maxillary excess than lip length.
Right. And so how do you correct something like this orthognethically?
You basically will, determine how much bone you need to move the maxilla to the right position. And when we're planning orthognathic surgery, we again have parameters that we go by to determine the optimal site for the edges of the central incisors and the midline and the I'm sorry? It's all cephalometric.
Is that all?
Now we do it, it's all computerized.
Right.
But, we have, all the studies and the parameters of where to place the incisors as we're planning the surgery. So we know how far we have to impact the maxilla up. Sometimes it goes up and forward a little bit. Sometimes it goes up and back, depending on the occlusion.
How challenging are those cases there?
They're a little more challenging because, if you're just doing a straight advancement or setback of the maxilla, then you've got pretty good bone contact. When you're trying to remove some bone to impact the maxilla, a lot of times you don't get great contact between the maxillary portion and the occlusal portion or the alveolar bone. So those are a little more complicated, and you can have more problems with those.
Do you end up with malunion or non-union in adults more than kids?
Definitely more in adults, especially the older they get after 35. But in a case like that, you may bone graft, you may put extra fixation so things stay stable. So even if you don't get a bony union, you've got your plates and screws holding everything in place. In general, patients over 35 don't heal from bony surgery as well as those under 35. So when we talk about, let's say, we talk about third molar surgery. If someone's 18, we'll take out all 4 wisdom teeth. If they're 25, there's slightly higher risk. If they're 35 or older, we tend to only take out the symptomatic teeth because at that point there's a greater risk than there is benefit.
Right.
So 35 seems to be the magic number, and especially 35 in male.
I broke my tibia and fibula last year, age 49, so I know all about bony healing.
Yeah, it can be slow.
Oh, yeah. Here he is. So now you're seeing a piece of it. You're not seeing all of it because in reality, when you look at his occlusal relationship, you're going to see something pretty disturbing in a moment. Look at the alveolar hypertrophy he has.
Oh, yeah. And he's got a narrow maxilla, too. He's got a crossbite on the
narrow maxilla. Yep. And look at the amount of space in maximum intercuspation from one ridge to the other. And this is a fistula.
Yeah.
If you do not do bone reduction for this patient, you're in deep trouble.
Yeah, you definitely have to in this patient.
And so we did something simple for him, Jay. We did an upper denture, lower all-on-4. No maxillary implants. Cobalt chrome, lower prostheses, 8 years post-op, Montreal design. That's what his tissues look like after I've removed his bridge. This looks a little inflamed because I didn't put a healing abutment on there, but not bad. Good carotid mucosa.
Yeah.
Good
kg
spread.
Yeah.
Yep. And he's using a water pick. He's not even super flossing. To be honest with you,
great.
I can critique this thing because you could almost see the suture line. You see that right here?
Yeah.
And so nowadays when we do these cases, Jay, what we're doing is on the day of surgery, we're taking out the teeth and Jeff is suturing. Then on the impression that I'm taking, I have the soft tissue moulage. I'm having my lab adjust the soft tissues to make them ideal on the model.
Mm-hmm.
Then I'm making the prosthesis on the model. I'm delivering it to do some kind of tissue conditioning. Because of the fact that this is bumpy, buccolingually, there's no way the patient can get in and floss.
Yeah, no, it makes it impossible.
Here he is. A pretty nice result.
Yeah, for sure.
Pretty anxious fellow.
Yeah.
I said, when are you going to come back and do your upper implants? He said, do you think I have the bone? I'm like, oh, yeah.
Yeah, you got plenty. May not be the right place, but you got plenty.
Right. If you can't change it, change your attitude. One of the reasons that I sold my practice and joined this organization is really because I was frustrated with the back and forth, sending patients, having treatment done, the treatment not really coming back the way I wanted it to, and also having a lab technician in-house for me is huge. I actually have 3 lab technicians.
Oh, Yeah.
And working with them day in, day out, it's allowed me to take my sort of quality of the work that I'm delivering to a little bit of a different level. Not because I'm a better dentist, it's because I have the whole team here.
Yeah, you've got all the tools, you got the team.
Yep. And now let's talk a little bit about digital cases. So here is a patient, partially edentulous, previous smoker, maxillary teeth are okay, mandibular teeth are not. And when you have a look at him in the maxilla, not terrible.
No.
Number 3 had fractured, we took it out. But maxillary teeth are savable. The game plan in the maxilla, this is a healing extraction site, is a single implant here, 2 over there, and that's it. Leave everything else alone. Mandible's a different story, because you've got a furcation lesion on number 19, number 22 is a goner, number 23 is a goner, 26 is a goner, 27 and 28 are good, and 29 is a root tip. So what are you going to do? You're going to make a partial denture with 2 teeth on them?
Yeah, no. You're crazy.
Here is the planning. I've done them, Jay. I mean, it works until you rock the teeth out of there with a partial.
Yeah, it works until you lose the teeth, then you go to full denture. So,
right.
Yeah, I mean, from looking at the long-term prognosis, it's something to avoid, I think.
Do you want to talk a little bit about the benefits of tilting implants and straight implants, Jay, or everybody more or less knows that?
I don't do a lot of tilted implants. I do everything with basically
Guided.
3D imaging, guided surgery. So I try not to tilt them. I know that's kind of the standard for all-on-4, which I've done a number of cases, although I haven't done the all-on-4 in a few years. So do you want to cover that?
The benefit of tilting the implants is really to increase the AP spread. You're using longer implants. And most of the time when we do an all-on-4, we're placing the implants between the mental foramina. Sometimes you'll do 6 and go distal to the foramen and anterior to the sinuses. Here are the measurements that I'm making. We want the 15 millimeter space. Here is the planning. You can see where the implant is emerging. Typically, we use either a straight or a 17-degree abutment on the anterior ones. Here are the images that are sent to me once we start doing these cases digitally. Anterior and posterior planes of occlusion, teeth over the crest of the ridge, confirmative or conformative approach where you're placing teeth where they used to be. You can see you're bisecting the ridge 2/3 of the way up the retromolar pad or halfway up the pad. Right side, left side, horizontal relationship, vertical relationship. I get all these screenshots. Provisional prostheses. Here's monolithic PMMA. Here is my surgical guide. This comes back to me for conversion, and the whole idea is this is monolithic acrylic. I still have to cut holes in it to pick up my copings. Supposedly it's stronger. They print a occlusal index for me. Not a huge fan. It tends to be, they slip a little bit. It doesn't index very well. I still use Blue Moose. Here are the PAs of my impression copings, Jay. So when we come to do our pickups, we're drilling 2 holes, picking up 2 copings intraorally, and then taking an abutment level impression, taking the case and mounting it, and now attaching everything. So here it is. You can see cantilever is long. We're going to shorten that. We're going to go to 3 bicuspids. Here is the soft tissue cast before it was modified and after. Can you tell the difference? So you can see the suture line horizontally. Now, however, look at how smooth that is. Look how bumpy it is prior to being adjusted compared to after.
Yeah, much smoother.
Allowing
smoother
you
and easier
a
to clean.
better. Yep. And what you're trying to do is tissue condition on the day of surgery because those tissues are still numb.
Yeah.
But you have to leave adequate room for swelling. Now is the cutback on the prostheses, applying composite, finishing, and I think that's too good of a provisional.
Yeah, that's nice.
Probably not. Too good.
That's always the danger.
That was my dad's expression, Jay. Never make a good provisional crown and never do a good reline for a denture.
Yeah, wise words.
Here's the prosthesis. Yeah. 3 months later, he's healing, and I said to him, "Are you ready to move on to the final teeth?" Guess what he said to me? You know,
No.
I don't think I want the final teeth. I'd just like to get the money back for those. I'll just go with these.
Yeah, I'm happy with what I got.
Yeah. As you can guess from my last name, I'm from the Middle East. I'm from Egypt. This is a pyramid outside of Cairo called the Bent Pyramid or the Pyramid of Dahshur. And they were building it and they realized geometrically that the base was starting to collapse. And so they modified the angle. And of course, it evolved into that. Those are the Great Pyramids of Giza.
Yeah.
So what are the pros and cons of tilted versus straight implants? Don't believe that tilted implants are better than straight. I don't. If you can get me implants straight up and down in the right position with a minimal cantilever spread, great. These are Astra implants with uni abutments and a CAD-CAM titanium bar with individual diatoric support. And these are Nobel implants. This is a Nobel Active. I believe these are Speedies. And it's another bar with different design. This is not what you want.
No.
This is a mess. What's the impact of the team's experience on success or failure? Very important that everybody knows what they're doing. Clinical accuracy is very important. So this is a verification jig to verify that my cast or my impression is passive and that my cast is accurate. This is after flasking and processing. Patient factors. This guy's a pack-a-day smoker for 10 years. 5 implants in the mandible, left his wisdom teeth. He comes back, he said, I got pus coming out of this. I said, how long has it been bothering you? He said, 8 months. It would have been nice for you to come in before.
Oh, yeah.
Patient factors are important, biological and psychological. Look at this mess. Bisphosphonate-related osteonecrosis of the jaws.
Oh. And did the
Not
fracture occur? I'm guessing there was an implant at that site and it fractured through, and you've got some osteonecrosis around it. Yeah.
Yeah. It's a mess.
Oh, yeah.
He was a smoker. Could you talk to us a little bit about the CTX test, Jay, and what it means and the pros and cons of doing it versus not?
Yeah. So the CTX test is the C-terminal protein of forget which one of the collagen fibers that's involved in bone production. So if you've got inhibition of the osteoblasts by a bisphosphonate, the CTX number will be let's see, it'll be wait a minute. So if it's if you've got inhibition by bisphosphonates, then you're going to have less cleavage of that C-terminal protein. And you'll have a higher value. If you've got lower activity, or is it related? Yeah, it's lower osteoblastic activity.
Yeah, because the medication affects
that's right.
osteoblastic turnover.
Actually affects the osteoclast.
Right.
Yeah.
But I mean, what I'm talking about is the relationship between the osteoclast and the osteoblast and the turnover of bone, right?
Yeah. It's basically, it measures the rate of turnover. So
right.
A higher number basically says there's more turnover. And
right. Which is what we want, right?
What it all means, so if you've got a low number, like less than 50, low CTX, and you've got less bone turnover, and that puts you in a higher risk category for osteonecrosis. Right. If it's above 150, then you have better bone turnover and lower risk. However, those numbers don't mean anything, and you can have a CTX of 300 and develop osteonecrosis, or you can have it 25 and develop it. So the CTX test really isn't done that much anymore. It gives you a risk factor index, but in clinical practice it doesn't tell you anything. And in the
it's a bit of an arbitrary number, right?
I'm sorry?
It's a bit of an arbitrary number, isn't it?
It's not necessarily predictive. So the AAOMS doesn't even recommend getting a CTX value. And it's been probably at least the last 6 or 7 years that they've recommend or suggested that's not useful at all.
The only reason we do it is CYA.
Yeah, I guess that's the only reason.
Yep. Sad. What role do provider factors play to the success or failure? Many. And lab factors. Basically, the general dentist and laboratory need to have an understanding.
Hmm.
Here is a patient with a removable prosthesis, cast framework that fractured. She comes to see me from Pendleton. She said, my bridge doesn't fit. She's got fracture prosthetic screws, calculus. And she said, you know, when he came to do this, the material got stuck between these teeth. And I said, yeah, that sometimes happens. She said, how many times does it happen to you? And I said, not many. And it happened with her because I've got to do an impression and then I have to make a new prosthesis and relate it. And I didn't use enough blue mousse to block out between these guys and the acrylic seeped in there. So it's very important if you're working with cold cure acrylic in people's mouths that you block out appropriately.
Yeah.
Not a great day. And you want to make sure that you have a good understanding of where your teeth will be relative to your framework. This is a removable prosthesis that is going to be retained by a bar, and you can see ample room here, not so much there.
Yeah.
Can't really grind on the titanium very much. You end up grinding on the teeth, which makes it a little bit weak.
Yeah.
So if you can get good synergy of the patient, the provider, and the lab, that can be the difference between success and failure. There are no secrets to success. It's the result of preparation, hard work, and learning from failure. So let's look a little bit about surgery. This guy's a trumpet player, upper and lower denture, tolerates the lower denture well, which is unusual, has 2 5-millimeter replaced select implants in a lateral in the canine position, which is bananas. Here is planning the case with immediate implant placement and removal of those implants, placing an implant in between them. They've been backed out. We're reducing the bone. You can see the old osteotomies, which we're going to graft. And here is the prosthesis in situ, or the surgical guide for me to check bone reduction. I still check bone reduction every day, Jay, even though I've been working with Jeff since 2013. Yeah. Invariably, that 1 out of 50 that I don't check doesn't have enough bone reduction. Because as a surgeon, you're trying to finish the case.
Yeah.
Without reducing more bone.
Yeah, if there's not enough bone reduction, right? Going back and reducing it more is not a simple task. So, yeah, it's got to be right for you.
No. In the first place. So here is the implant preparation, the osteotomy, checking to make sure there's no connection or perforation to the nasal cavity. Implant placement. I still need some more bone reduction. Tilting the implant, placing the implant, getting enough torque. And there's what this typically looks like with the 30-degree abutments in the back and straight abutments in the front. And you can see everything's a little bit palatal before this has been grafted. He's always taking a post-op PA to make sure his abutments are down, because sometimes you're going to have to do some bone profiling. Maybe you could explain what that is, Jay, please?
So if you've the osteotomies, the drills are basically straight. So when you place an implant and it's like at an angle like this, or it's a little subcrestal, that the contour or the kind of the slope of the apical surface of the abutment sort of gets stuck on the bone. So you can't seat the abutment all the way down because bone's in the way. So a lot of implant systems have what's called a profiling drill, which essentially what happens is you screw a guidepost into the implant, and then there's a trephine cutting drill that will remove and contour the bone to allow the abutment to seat.
And what happens if you don't use it and your abutment doesn't go down the whole way and you find out after the fact? You're in kind of deep trouble, right?
I mean, you can go back and profile the bone after. We've had some cases where we placed a healing abutment when we placed the implant slightly subcrestal, and when we went to place the final abutment, it wasn't seating. So we just take out the bone profiling drills and take care of the problem there. But if you're doing, an
First
all on
time
four, it's a different situation.
First time I ever ran into that problem, Jay, was working with a student. His first name was Jay. He was a dental student. Congenitally missing two laterals. No, congenitally missing two cuspids. He had retained deciduous teeth. We decided to take them out, place implants, provisionalize, and I finished the case. And I took a PA, and neither of the abutments were down the whole way.
Yeah.
Replaced the leg because they hadn't been profiled.
Yeah,
I went back and profiled it.
Oh, sorry. I was going to say, whenever we place a healing abutment or an abutment, we always get post-op PAs to make sure the abutment's fully seated. Yeah.
So here they are. Here is the provisional prosthesis, which is his old denture that I converted. Here he is on the day of surgery. The reason I showed you that, I just wanted to get an idea of the surgical sequence.
Yeah.
Is the evidence robust for all on four? Some people say yes, some people say no. Some people are skeptical. I was skeptical. The very first time I looked at an all on four was in 2010. I got sent a case by an attorney to review, and I read about it, and I thought, nah, 4 implants aren't adequate in the maxilla. My experience in my residency told me that maxillary bone was poor, and 4 implants weren't going to do it. You need 6 or 8. And that's a bit of a dogmatic opinion.
Yeah.
I felt comfortable with 4 implants of the mandible because I'd done mandibular all on 3s. So this is a paper that Tara Agaloo and Tom Taylor and Polito published. It's a meta-analysis. They looked at a lot of articles, 1,533, and they saw what met criteria and eligibility and so on. Ended up with 93 studies, and they reviewed the results. That's pretty robust, I think. They found was evidence from this review and meta-analysis suggests that using fewer than 5 implants per arch, when compared to 5 or more to support a fixed prosthesis of the completely edentulous maxilla or mandible, has a similar survival rate with no difference statistically at the 0.05 comfort P level.
Okay. Yeah, I've seen that.
Let's talk about failure. Here's a patient who had a complication. Partially edentulous, retired from the Army Corps of Engineers, moving down to Phoenix, didn't want to spend all his money, said, I want an upper denture and a lower bridge. So I did that. Came back 2 weeks later, he said, I hate this denture. I can't talk, I can't breathe. Can you do something for me? So we placed 4 upper implants, and my surgeon said, you know what? Because of the AP spread, I'm not going to use a tilted abutment here. I'm not going to use an angled abutment. I'm going to use a straight abutment, improving your AP spread by having a shorter cantilever.
Yeah.
But now we've got a little bit of divergence in terms of the path of insertion. And this implant never really healed great. I proceeded and switched out the abutment. You can see there's a different angulation here. Switched out that abutment from a straight to a 30 degree. And then here are my PAs on the day of a framework trying. It's still symptomatic. I said, John, we got to stop.
Yeah, it looks like there's some bone loss
we thought
there.
this thing was going to heal. Yep. And so what we did is we removed the implant. I processed his bridge with a titanium bar with a cantilever in 5 and 6. We took it out and grafted it. He's a smoker. Waited. Came back and placed an implant in the tuberosity and one in number 5. Submerged them. Eventually uncovered them and put healing caps on multi-unit abutments. Went from that to that and then connected. So failures will happen. Invariably, they're more in the maxilla than the mandible. Almost always. And I believe that's related to 2 things. Poorer bone quality and sometimes poorer bone quantity.
Yeah. It's,
Don't know how you
in
feel
general,
about that.
with implants in general, that's what we see. Yeah. Higher maxillary failure rate.
So let's look at this study from Marlowe where he looked at the edentulous mandible with 10 to 18 years follow-up. And the question was, is there an impact by systemic disease? So they looked at 1,884 implants, 10 to 18-year follow-up, 471 patients. Primary measure was the prosthesis survival, implant success and survival. Results, 6% of the patients died, 32 were lost to follow-up. So they were able to follow up a good amount. 62% came back.
Yeah.
The prosthesis survival rate was high. Implant survival rate was high. and implant success rate was a little bit lower. And Jay, you want to talk about the difference between
Yeah,
survival
I mean,
and
we
success?
talk about survival versus success. So survival is an implant that may have some bone loss around it. It may have lost 50% of the bone loss, 50% of the bone, but it's still stable. That's implant survival, where success rate is when you have good bone level, good soft tissue health around the implant. That's a success, as opposed to just an implant that's barely that's surviving. Not necessarily barely
Right.
surviving. But.
Essentially, you have more strict criteria for success than survival, right?
Right. And yeah, we strive for success, but sometimes we have to satisfy or just compromise and just live with survival.
Yep. So previous biological complications are associated with implant failure. So patients that had periodontal disease may be more predisposed to implant failure. Patients who are smokers may have more implant failure, and patients who are poorly controlled diabetics may have higher implant failure. Biological complications were 12% at the implant level, like we talked about, smoking. Mechanical complications with male patients were high, and the prosthetic material absolutely was associated with failure. Highest rate of failure was in plastic, then plastic metal, and then least was PFM. Now look at the difference in success when you have a systemic condition versus not. So when you have a systemic condition at 10 years, you have about 98% CSR compared to a systemically compromised patient, about 4% lower.
Yeah.
So I definitely believe that systemic disease has an impact on overall healing. And we know there are papers that came out that talked about proton pump inhibitors and selective serotonin reuptake inhibitors and how they impact. Maybe you could talk to that, Jay.
Yeah, so there have been multiple studies looking at patients who are on SSRIs, so like Prozac and Wellbutrin, all the selective serotonin reuptake inhibitors. And they don't really know the reason why, but there's a statistically significant increase in implant failure in patients on those drugs. That hopefully they'll.
I actually read it.
And if the patient's on an SSRI and smokes, the risk goes way up beyond just the smoking alone.
What about SSRIs and bruxism, Jay?
A lot of patients who are on the SSRIs are anxious. They, may have a little more bruxism, and the way that the SSRI affects the bone healing metabolism. If they're bruxer with implants, that may lead to increased implant failure.
And what I've read about SSRIs and bone turnover, it's not initial healing. It's again the osteoblast balance in the future.
Yeah, more long term.
So it's not only affecting the bone, it may make them be a clencher or a grinder. Now you're stressing the bone and the bone is weaker. Mm-hmm. So there's definitely a correlation between the two. Here is the marginal bone loss between 10 to 15 years. There's a wide range there. And a provisional prosthesis that's fractured with no metal in it. That's what it can look like, catastrophic. Mm-hmm. Higher rate of mechanical complication in male to female, absolutely. And then here are the complications that they had. Provisional prostheses, 18% fracture. Abutment fracture 0.2. You only get an abutment failing when it's been torqued or abused or reused when it shouldn't have been. Abutment screw loosening, that's a high statistic. For us, abutment screw loosening is in the 1 percentile because you're able to torque those to a high torque. Prosthetic screw fracture happens. Prosthetic screw loosening, we tend to see it in a bruxer higher than 0.6%. For sure, this is the biggest. This is the biggest complication we have. Yeah. Acrylic teeth. Forget about ceramic crown and acrylic crown fracture because they had some cemented stuff. Cylinder fracture, that can happen. That's the coping, and that's typically on the distal cantilever. Prosthetic gingiva fracture, you will see that because it is acrylic. Again, abutment fracture, I'm perplexed by that. Abutment screw loosening, they may not have torqued them or retorqued them. Mm-hmm. And then prosthetic screw loosening will be higher than the definitive prosthesis rather than the provisional by virtue of the fact that they use this for much longer. Yeah. So that all makes sense to me.
Yeah. Do you, Sam, do you have a certain implant type or system or abutment that seems to get more screw loosening and screw fracturing than others?
Great question. So we use multiple different implants here. We'll use Astra implants, the 6 millimeter implants for patients when we need to use short implants, but I won't use those for an all-on-4. Typically, the implants that I'll use for an all-on-4, I'll use Nobel sometimes, and those we tend to use the 3.3 millimeter Speedies.
Okay.
We'll use Neodent implants. Basically, that's a Nobel clone.
Right. And now with the internal with a trilobe or
great
or
question.
the bone level connection.
Yeah, so we used to use external hex. So when you have an external connection implant, you typically will have a slightly higher rate of mechanical complication because you've got a flat top to a flat top connection with not very short, not a very tall height. So internal connection implants are definitely to have a higher fidelity of fit. And we've been using Neodent now for about 3 years. Mm-hmm. And they fit fantastic. The abutments fit great until you want to remove an abutment and switch it out. You torque that down, and it has an internal Morse taper. You get a cold weld, almost like an ankylose. Good luck removing it. Mm-hmm. I've had abutments where we've taken out the abutment screw. The abutment screw is out, but we can't get the abutment out. We have to use a rongeur and almost extract it out. So, the deeper your internal connection, the better fit that you're going to have. But if you have a problem, those stresses are way deeper inside the implant and can lead to an implant body failure or an implant fracture. So there's no perfect system, right? It's just biomechanics. It takes 20 years to build a reputation and 5 minutes to ruin it. If you think about that, you'll do things differently. I've been here for 18 years now, and I got about another 8 or 10 left in me till my kids go off to college. So, the failures that I've had in my private practice, they know how to find me. They come to find me and say, hey, what can you do different? Mm-hmm. And I look at some of the stuff that I did, and I'm a little shocked, a little perplexed, but I didn't really know enough about bone reduction. And it's interesting, Jay. I spoke in Gothenburg in 2011 for Dentsply on fixed hybrids, and I've probably done 30 in my life. And I thought I knew what I was talking about. And now I've done a couple of thousand. I'm like, oh man, can I have a mulligan and redo that lecture?
Yeah. Oh yeah.
But the more you do, the more you learn.
Yeah, exactly. The more you do, exactly. The more you learn, and as you said earlier, you learn more from the cases that didn't work than the ones that are successful. Sam, I want to thank you for taking the time out of your schedule to. I'm sure you want to be home with your family, and you've been gracious enough to spend almost 2 hours with us. Really educating us on the all-on-4 system and restorative, the prosthesis options and the technique.
Yeah, I guess I want to wrap up, Jay, by saying the following. It is a technique. It's not the technique.
Right.
I still make overdentures, Jay. I do mandibular 2-implant overdentures with locators. I'll do maxillary overdentures. I mean, once you place 4 implants in the maxilla, I tend to lean towards something that is fixed. But I've had patients, 2 of them, in the last 8 years that I did something fixed for and said, I don't like it. I want something removable. So we still use the implants with multi-unit abutments and a bar, and I make something they can remove so they can clean it.
Yeah.
So it's not one size fits all. And I guess perhaps that's the take-home message I want your listeners to understand, that this is not the only thing that's in my repertoire. That tends to be what I do, but not every patient who comes in requesting it gets it.
Yeah.
I refer patients out for ortho, perio.
Yeah, that's definitely, there's everything we do, there are treatment options. There is no one way to do things. Well, thanks, Sam. I guess that's going to wrap it up. We'll let you change out of your scrubs and go home. So want to wish everybody a pleasant evening and all the best. Stay healthy, stay sane, and we'll see you next month.